So welcome everybody. A very good evening and welcome again to this session of Mission Mangal by SFM Telangana team. And we thank our mentor emeritus, Professor Ashok Khurana, and our president, Dr. Mohit Shah, and our secretary, Dr. Reema Bhatt, for giving us this opportunity to create, online educational programs. And the topic for this particular episode is taking lessons from fetal autopsy. As we all know, the loss of a fetus or the termination of a pregnancy or any kind of miscarriage in pregnancy is a very, very sad situation. And many people think that this is the end of the story of the pregnancy, but actually it is a beginning of a whole lot of investigations which will help in finding out why things went wrong and what can be done to avoid these problems in future. So we have named this particular topic as fetal autopsy. It's not a lost cause as long as you can gain insights for the future. We are very lucky to have with us Dr. Shagun, who's the dynamic secretary of the SFM Telangana, and she has curated this entire program. She's brought together the experts and drafted the topics in a way that we will really gain insight into something that can be implemented to get a better perinatal outcome in the next pregnancy. So with these few words, I want to hand over the proceedings to Dr. Shagun, and she will take it forward as the convener of this program. Dr. Shagun, all yours.
Thank you, Dr. Chinmay. So once again, everyone, welcome to today's program. So Dr. Chinmay has already set the stage, so to say. So I think without further ado, we'll go ahead with the program. So Dr. Aditi, please introduce our first session persons and speaker, and let's start the proceedings.
Good evening, everyone. I hope you're all able to see this screen. So this is our program for the day. And as you can all see, our session 1 is called Setting the Stage. So here we would like to give you a pathologist as well as a geneticist perspective towards fetal autopsy. Our chairpersons for the day are Dr. Kamlakar sir and Dr. Reema Bhatt ma'am. And that is Dr. Reema Bhatt ma'am. We know all of us know her. She doesn't need much introduction. She's has served as a senior advisor in the prestigious AHRR in Delhi, and now she is in the Amrita hospitals also in Delhi, and she is a professor and head of fetal medicine and perinatology over there. Kamlakar sir, he's one of our very, very senior and esteemed faculty. And he is very, very keen teacher, and he trains multiple radiologists and gynecologists. And he's been doing that from 1998. And he's currently running Shravya Scan Center till date. Next, of course, I'd like to introduce our first speaker, Dr. Aditya Kulkarni. He is the consultant at AMPATH, which is Histopathology at American Institute of Pathology Lab Services, and has special interests in placental and perinatal pathology, gynecologic pathology, and also has, very interestingly, interests in artificial intelligence and computational pathology. With that, I think I would request Dr. Aditya sir to start his talk.
Yeah, hi. Just let me start the open the thing.
While Dr. Aditya is setting up, if Dr. Reema or Dr. Kamlakar sir want to give any inputs, please do.
Good evening, Dr. Reema.
Yeah, good evening. I was muted. I could not talk. Thank you for this invite, and I think it will be a great session. Your Dr. Chinmay is coming up with some wonderful sessions that are really important as far as our practical tips in fetal medicine are concerned. I think this will be really good. I think our speaker is ready to share.
Yeah, sorry, I just dropped, my internet just dropped for a moment. Yeah. I am audible, right? Everybody able to
Yes,
hear me?
Dr.
Yes,
Aditya, please
yes.
go ahead.
Thank you, ma'am. Yeah. Yeah. So I think that's full screen. Yeah, so I'm just going to briefly talk about what we do from the in a fetal autopsy from the pathologist's point of view, and we are briefly going to discuss what are the indications, when do we want to do an autopsy, and how it is going to help, what are we hoping to achieve through an autopsy examination. And then just because I'm a pathologist and I can't help but tell the clinicians that we need proper history anytime, any chance I get. So we'll discuss what are the prerequisites of the fetal examination. And then in detail, we'll discuss how to go about a fetal autopsy examination, at least from our point of view. Okay. So the question of why do an autopsy is an important question, especially in the context of Indian scenario where the couples may not be uh, all for it always. They may be reluctant about it. But the thing is, we are trying to help the future pregnancies. We are trying to figure out what went wrong in this pregnancy and trying to see whether this is going to be a recurrent problem, and that is how we are going to help. Okay. Uh, then how do we approach the fetal autopsy? Because it is the examination of the entire body and of the placenta if it is available. So the only way to do it is in a systematic way so that you don't miss out on things. You do you are a thorough and as detailed as possible. That is how you should approach a fetal autopsy examination. Fetal pathology in India is a burgeoning field. It's been there for quite some time, but it is now growing. There is a couple of dedicated centers now. There is a Mediscan Chennai Mediscan in Chennai, and then there is a couple of fellowships even. So we are slowly getting there, and so that brings us to the question of what are the indications. So when does someone order a fetal autopsy? So the most common indication that we get in our practice is that intrauterine fetal demise, especially late fetal demises where where the couples really want to know what went wrong and why how they can help in the next pregnancy. So these falls under three main categories where there are known maternal medical conditions, and you want to find corroborative evidence of that in the fetal and placental examination. Similarly, when there are fetal causes that you know, be it renal agenesis or be it other fetal causes or be it infections, so where you know where you at least suspect a fetal cause and you want to find evidence of that. And then most importantly, causes which are not straightforward, which are so-called unexplained fetal demises. So in fact, in a study, it was noted that without a fetal autopsy, as much as 80% of the cases were labeled unexpected fetal demises, and with fetal autopsy, that number dropped down to 15 to 20%. So that is where the fetal pathology and fetal autopsy makes its impact. Neonatal deaths is the separate is another aspect of the same equation where the baby is fine and then it passes away, and then we want to find out what was the problem. And then the big chunk of the fetal autopsy examination is because of termination of pregnancy, because of many other causes, whether they are congenital anomalies, and we want to document those anomalies, or there are any abnormalities in the US scan, ultrasound scan, and we want to find out if there are other abnormalities associated with those, or if there are isolated anomalies. So these are the reasons why we do a fetal autopsy. So this slide is the extension of the previous slide. So we want to determine the cause of death, and we want to assess the recurrence risk. These two are the main objectives that we have. Then again, detection of congenital anomalies, documentation of them. We are trying to corroborate or trying to refute clinical diagnosis, as the case may be. And then to a certain extent, determination of the gestational age and assessment of the time since death. So this last is sometimes requested by the couples also. And it's, while it is not an exact science, because it all depends on the maceration and other factors like that, fixation, things like that. But we still try to make an attempt. And what does all of this do? What do we do using this fetal autopsy technique? Is we are trying to give closure to the parents, and we are trying to help their clinicians, the team, to come up with a further action plan, and we are trying to give a more fruitful counseling experience, let us say. It also serves as a quality control for antenatal investigations, where you have ultrasonography findings and then you are using fetal autopsy as a QC for whether to see those findings are still actually there. And then we are actually contributing to epidemiological data also. So what are the prerequisites? And like I said, this is what every pathologist I know tells every clinicians they know, that we need detailed clinical history, and that comes in terms of request forms. We generally request for all the antenatal investigations, especially scans that have been done during the course of the pregnancy. And if required, if anything is supposed to be conveyed to us, we are always open for discussions. In fact, we sort of prefer when clinicians call up ahead and then send the autopsy to us. So because the dialogue is important, the rapport is really important. And then the next aspect is the written and informed consent. So here we actually used to have we used to insist that the couple, or at least the father of the baby, comes in person with the sample. And so we used to have a one-on-one counseling session, and then we used to explain the procedure to them and take their consent there. The sample transport and fixation is important in terms of that the baby does not get distorted and the baby is fixed properly. So we don't generally prefer the sample sent to us in saline, especially because we don't have a genetic setup as of yet. So what we do is we insist that any genetic samples have to be taken beforehand, and then the baby is put in formalin as soon as possible, and adequate amount, at least 10 times more is what the books recommend. So 10 times the volume of the baby, that much amount of buffered formalin is required, and then proper packing and transport, that all of that. We accept cases for from 11 weeks of gestational age to 7 days of neonatal life. Before that, organogenesis is not really complete, so it's not really worthwhile. And beyond that, causes of any neonatal demise occurring because of perinatal milieu are sort of less. So this is the criteria we have. And these are the forms that we have developed just to make sure that all the information comes to us, even if the investigations sometimes are not sent. So we have indication, and then we have gestational age, obstetric history, pedigree chart, family history, and the scan findings. Similarly, this is the consent form that we have. We basically give a broader overview of all the things mentioned here, and then we take the consent, and it is also available in Telugu. And this is how we want the samples to be ideally transported to us in a big container, so that the baby is not touching any of the sides, so that it does not get distorted. It's not stuffed inside the container, and then adequate amount of formalin. So what are the components of fetal autopsy examination? So this is the bulk of the talk now, and I don't have so much time, but we will try to look into this one by one. So what we do is a radiological examination of the fetus, then a thorough external examination, then an internal examination where we are dealing with each organ and organ system, placental examination if the placenta is submitted, and then microscopic examination. So all of these findings, all of these together will constitute a fetal autopsy examination, and this is what This is what is needed. Like I said, this is the systematic approach. So radiological examination is mandatory for each case, and you can have a lot of information here. So you can have determination of fetal maturity, whether it is in accordance with the scan findings, or whether it is lagging behind, or whether it is uh, correlating with gestational age. And moreover, more than that, you can with phytograms, you can actually diagnose a lot of congenital anomalies, especially skeletal dysplasias, but also certain aneuploidies, and then other even non-genetic anomalies, like for example, meconium peritonitis, you will find uh, calcification in the abdominal cavity, things like that, or pneumothorax, you might find air in neonatal nemesis sometimes. So based on the appearance of ossification centers in the fetus, that has a specific sequence, and based on that we try to correlate them with the gestational age. So this is the radiologic examination. For example, these are the few findings that we have come across in our practice. So this is the thanatophoric dysplasia with your typical shortened and telephone handle femora. And then this is a very rare case of Fatco syndrome, which is Phibia amelia tibial campomelia. So you have a tibial bone which is bent, and this has a bony spur, and then fibula is absent. So this is actually something like a fibular ray deformity, where you have this baby had only 3 fingers on one foot. And then you have chondrodysplasia punctata, which is quite common. We keep seeing it. And then you have this punctate calcification in the joint spaces. So, so these are the radiologic findings. Then external examination, again, you are trying to be as systematic as possible. So you do a detailed morphometric analysis, which is where you measure the uh, various aspects, various dimensions of the fetus, and things like weight, and then crown heel length, and crown rump length, foot length or toe heel length. And then some people, in fact, do measure like mid-arm circumference and thigh circumference and things like that. So head circumference is important. Inter-inner canthal distance is important. So these basically you're doing morphometry to find whether whether the growth is lagging, or whether the growth is according to the gestational age. And some of these are more sensitive than others. Toe heel length is the best. For example, toe heel length is the best indicator, best metric that correlates with the gestational age, correlate with the actual age of the fetus. Then you go to the external features that you are seeing. So for example, you go again system wise, again let us say region wise. So you go for head and all the facial features. So here you are trying to look for things like Potter sequence, where you have low hairline and hypertelorism and receding chin, and this sort of picture. Then you have you go examine for trunk and limbs, where you have abdominal distension, if it is there, whether the thorax size is normal, uh, things like that. And all of this is giving you pointers about what it could be. For example, if it were a case of thanatophoric dysplasia, you will have shortened limbs and you will have short, narrow thorax, and that is how you will suspect it. So, of course, limbs comes, you have this hand and feet examination also. This is a case of syndactyly, for example. I'm sorry, the picture is not really clear, but the baby was really small. And then you are looking for external genitalia, which is part of perineal examination, where you are identifying and confirming the sex of the fetus. And then you will document additional features, such as if there is presence of maceration. If it is there, how much is the extent of maceration? Because what like we said, we want to, as much as possible, we want to assess the time till since fetal death. And then other features, like features of fetal distress, sometimes you can see like hyperpigmented lips and extended posture, things like that. So these are other features that we have seen. See, so this is arthrogryposis, which is joint contractures. across the joint spaces. And then this generally occurs in cases of extreme anhydromnios or associated with Potter sequence. So in this case, I would also go and look at the placenta, and I will look for amnionodism and if there is any antepartum hemorrhage, things like that. So this is what, so basically every single finding that you get is a pointer for you to look at other things and look at everything else. Okay. So this is a case of occipital meningocele, just to show, and then this is a polydactyly. All four limbs have extra fingers here. So just to show an interesting finding. Then coming to internal examination, now there is a lot of variation between how you open up a fetus. Everyone has their own preferred method. What we generally do for head, for the cranial cavity, what we do is we do a horseshoe shape or an inverted question mark like incision, where you go from one ear to the other ear and then extend that same cut across the occipital bone and down the neck. So this is like a question mark, and then that opens that opens the cranial cavity. Then you excise, you take out the brain. You first, whatever cavity you are opening, you do an in situ examination, and then you eviscerate the organ. So this is a normal brain, for example, with normal corpus callosum, and then parieto-occipital fissure, and then calcarine fissure. So again, this is also where it gets a little bit detail oriented, where you document how many sulci are there and how many gyri are there, and based on that you can actually assess the gestational age of the fetus. This is a case of agenesis of corpus callosum. Then similarly, the thoracic and abdominal cavities, everyone has their own ways of their own preferred incisions. What we generally do is inverted Y-shape incision. So you go from this the symphysis mentae, and then down the midline, and then around the umbilicus you do the prongs of the Y, and then that is how you can open the thoracic and abdominal cavities. Sometimes when we don't have to return the fetuses, we just take out all of those flaps so that the in situ examination becomes easy. So for example, in this case, you can identify the bladder, and you can see both the umbilical cords are there, both the umbilical arteries are there. You can see the internal genitalia, that are bilateral testes are there. And then thymus is in the proper location. And then there is some hemorrhage in the pleural cavity, which tells us this is probably some sort of post maceration effect. So again, there is an aspect of morphometry here also, where you are taking weights of each of the organs that you have taken out, and you are assessing that weight against the normal for that gestational age. So this set of standards are there, and then you are assessing whether it is more than the normal for gestational age or less than normal gestational for age. And then you take sections. Basically, you go system wise, you take out each organ and each organ system. And you then take sections from each of them, and then you can proceed to microscopy. Then again, just to show a few findings, this is the case of bilateral renal agenesis. You can see that the renal fossa is completely empty here. And then this is the classical lying down adrenal, the flat adrenal that I am at least very fond of that finding. Then this is the aberrant subclavian artery, where the subclavian artery is actually given as the fourth branch of arch of aorta, instead of coming off from the right brachiocephalic trunk. And then this actually crosses the midline posteriorly and then goes to the right. And this is one of the most common congenital anomalies actually recorded. And then this is, by contrast, a very rare anomaly, where this is a persistent cloaca. You can see, let me just show. This is the this is a genital tract, urogenital tract, and then this is the intestine, and all of that is opening in the same single opening. So coming to placental examination, and this is where you really do need a placental pathologist, someone who is trained and who is aware of the things that you want to see in the placental examination. So again, it's a very complicated and very unique organ, and you need to do a systematic approach. So especially similarly to the fetal autopsy, you do gross examination and microscopic examination. So gross examination you will do umbilical cord examination, and it has its own things that you look for, like number of coils and number of vessels, and where is the insertion, is there a filamentous insertion, and all of these findings are significant. In filamentous insertion, for example, the fetus runs the risk of exsanguination by hemorrhage. So these things are important to document. And then membranes, you can get clues where if they are opaque and they are foul smelling, then you are suspecting a chorioamnionitis, and then you look for the findings of those. And then what we do is we examine the fetal surface and then the maternal surface, and then we take sections. And this is how we'll sample them. And this is a case of IUFD, for example, and you can see extensive infarction here. Both the well-established infarcts, which are gray, and then the new infarcts, which are brownish. So infarcts of various ages, so multiple insults over the course of the pregnancy. And then microscopically also, you have the, again, same compartment-wise approach. You examine the umbilical cord, then you examine the membranes, then you examine the fetal vasculature, and then you examine the placental parenchyma and basal zone. So this is how you proceed. And as far as fetus is considered, we take this long list of sections. Brain, especially when it is not autolyzed and it is preserved, relatively preserved, then we can take brain sections. Thymus is important, lungs, and pancreas, kidneys, adrenals. So, and examining fetal organs microscopically has two benefits. One is that you can find, of course, pathologies like hepatic steatosis sometimes, or this is a case of multicystic renal dysplasia, where you can see these dysplastic malformed tubules with surrounding immature mesenchyme. But more than that, you can also actually do, again, gestational age determination based on microscopic examination, because these are growing organs in fetal life. They will grow, and their internal morphology, anatomy changes, histology changes as they grow. And then, for example, in lungs, you have this embryonic stage, and then canalicular stage, and then alveolar stage. So based on that, you can have an idea of what is the gestational age, or is it lagging behind, especially in cases with anhydromnios, where there is pulmonary hypoplasia, and then you can actually see that it is there. So this is just to show the normal kidney. I'm sorry, I forgot that was there. You also do, in relevant cases at least, we do examination of the bones. So this is the first case of thanatophoric dysplasia that we discussed. So this is actually a normal epiphyseal plate. You can see orderly columns of these maturing chondrocytes. But here all of that is haphazard, and then there is areas of fibrosis at the periphery. So this is a case of thanatophoric dysplasia, and this is how the diagnosis is made, because campomelic dysplasia, for example, can also have shortened femur and can also have bent femur and all of that, but it won't have the haphazard ossification of the thanatophoric dysplasia. So this is where the diagnosis is clinched. So, and then similarly, you have a plethora of findings in the placental pathology also. I'm not going to bore you with this, but these are some of the easiest things that we look for. This is acute chorioamnionitis, which is like a inflammation or neutrophilic inflammation of the membranes. This is histiocytic intervillositis, where you have these aggregates of histiocytes within the intervillous spaces. And this is extremely important to diagnose, because this is one of the most common or most significant, let us say, causes of unexplained IUFDs. And what happens is, this is generally not picked on scans, and this is actually important to identify pathologically, because histiocytic intervillositis has an extremely high recurrence risk. So almost as far as 75 to 100% of cases recur in the next pregnancy. So it's important to know these things. Similarly, maternal vascular malperfusion is probably the most common thing that we see, where you have these vascular changes of decidual vessels, which are showing this fibrinoid necrosis and then chronic inflammation surrounding them. So this is what actually is a result of the hypertension. Maternal hypertension is, you can see that you see in the hypertensive disorders of pregnancy. And then you have features of hypoxia in the feet, in the chorionic villi, like infarction is there, and then increase in facial knots is there. So this is also important to know because maternal vascular malperfusion has around 20% recurrence risk. More important than that, this is now known to have long-term non-obstetric complications for the mother. So the mother is actually at a higher risk for developing cardiovascular episodes later on in life, and that is why you should diagnose this as a pathologist. So once all of this is done, once you are ready with all your autopsy findings, what you do is basically you have to collate them together and you have to come to at least a provisional diagnosis. Essentially, this is going to be a morphologic diagnosis because we are not confirming it with genetic studies. Next speaker will probably talk about that. And then we also try to do, if especially when it is required or when it is asked for, we also try to do a post-autopsy counseling where we explain the report to the couple in as simple terms as we can. And then if required, we always are open to discussion with clinicians. And then based on all these findings, we can in fact go for further testing, be it for the baby or be it for the genetic testing. So to summarize, this is what we try to do. We try to help the next pregnancies. We try to help the living by studying those who could not make it. Thank you.
Thank you so much, Dr. Aditya, for that amazing talk. I think, Shagun ma'am, we could go ahead with the next talk and then have a discussion at the end of the session, if you permit. So I'll go ahead and introduce our next speaker. Our next speaker is Dr. Priya Ranganath. She's a consultant medical geneticist from the prestigious NIMS, and her expertise is in reproductive genetics and understanding and interpretation of exome data, pediatric genetic disorders, and management of genetics of intellectual disability and autism, and also takes expertise in genetic neuromuscular disorders and oncogenetics. With that, I would request Dr. Priya to give her talk, please.
I hope I'm sharing my screen right. And thank you so much for giving me this opportunity to present at this wonderful SFM Mission Mangal program. And I'm really happy to provide a genetic perspective. I hope I'm audible and my slides are visible.
Yes, Dr. Priya, go ahead.
Yes. Right. Thank you, ma'am. So thank you, Dr. Aditya, for that very detailed introduction. And we also, as geneticists, look at probably some of the aspects. There's some intermingling in the initial aspect of dissection and consent giving that we also do. And post that, the histopathology aspect, which then goes, and the placental aspect, histopathology of the placenta, then goes to the histopathology examination. I'll try to just touch upon the genetic aspects of these so that we don't mix with a lot of talk that you have already heard. So, of course, autopsy is a very specialized procedure, and understanding on how to perform this autopsy is very important before we give these expert understanding to our patients. Now, we know congenital malformation is the commonest cause of perinatal death. It contributes to 10 to 15% of mortality in the perinatal period in India. And we have the 3% of all neonates have major congenital malformation. So we have covered this. So why should we offer a fetal autopsy? So of course, establishing cause of death is very important, especially when it's associated with genetic disorders and malformations. Some USG-related scan findings that we pick up during TIFA scan or other scans that indicate towards a genetic etiology becomes very important. And these scans can also, autopsy can also help us to confirm some of these anomalies that we pick up in scan, and some that are very difficult to pick up in scan. For example, cleft lips, cleft palates rather, small isolated cleft palates, and some cardiac anomalies, which can be very difficult, and some CNS neural migration disorders, which can be picked up very easily in scan, can be well established through fetal autopsy. Now, the main intention of doing an autopsy, as Dr. Aditi already said, is to assess the possibility of recurrence, whether we're looking at a genetic cause for this, and to prevent it in the future pregnancy and give them a prenatal diagnosis if required. So we do perform these steps where we take detailed history, a written consent, we do sample collection for genetic testing, followed by storage and fixing. Then we do go through fetal radiographs, fetal anthropometry to establish our diagnosis in case of suspicion. We do detailed fetal photography for document keeping so that we can always come back to the phenotyping once we have the genetic report. We do a detailed external and internal examination. And in the genetic aspect, we also do this external examination, keeping in mind a dysmorphology assessment, because many times looking at the baby itself kind of gives us a clue as to what genetic disorder we might be looking at and will help us to determine the exact genetic testing that we want to do. Then planning a genetic test and the histopathology report. Now, a detailed history is very important, a detailed antenatal history, previous obstetric history. We did the pedigree analysis last time, so understanding how to draw this pedigree, seeing what else could be there in the family history, what else in the previous antenatal history, will really help us to understand whether we're looking at a genetic cause or a non-genetic cause. And also, when you take the detailed history, all the previous investigations have to be checked. Please document it within our case sheet or performer that you have prior to doing the autopsy. All this have to be done priorly. And any parental workup which has been done, be it for torch infections, be it for even like genetic testing, which have been done for previous pregnancies, also need to be collected well in advance so that we can give them a most appropriate result, or result which is more comprehensive and more significant for them, so that the next pregnancy they can avoid something like this, and collect all the documents and scan priorly. Now, this is what it looks like. I always prefer to have a doctor's referral form. So in the doctor's referral form, they would also put in the indication for autopsy. Make sure that they tell the date, time of receiving conceptus, date and time of gestation, the sex of the fetus. Sometimes it's important to write down for purposes of documentation, and then also all the attached previous obstetric scan and medical records need to be attached with the referral form. Now, it's very important to take a detailed consent form. And by detailed consent form, I want to emphasize that it's important to take consent for many of these procedures and not blanket this under everything. So it also ensures that you've explained what's the process of taking autopsy and also or doing autopsy, and what you'll be doing over this period of 1 to 2 months, because it often takes time to fix the tissue, to do the assessment, to fix the tissue, then send it for histopathology, and by the time the report kind of comes in, it takes around 2 to 3 months to have your final diagnosis. So giving an understanding prior to doing the autopsy is very important, and take consent for detail each and every part of the examination, and showing the patient that they could opt out of any of these examinations if they are willing to. So all this need to be taken, and also whether the baby need to be returned to the family or sent to the burial ground, all those has to also be taken within the consent forms. Now, coming to photo consent, it's important for a geneticist to have the photo consent form, because we always go back to the photos to look at dysmorphology again, to understand dephenotyping again. So please do take the photo consent form. And keeping all these documentation ready prior to starting your autopsy procedure is very important. Now, as it's been already mentioned, that prior to putting the baby in the formalin, we need to collect the samples for genetic testing. Otherwise, once the baby is put in formalin, the DNA degrades and no genetic testing can be done for the same. So it's very important to take 2 ml of EDTA blood. If possible, 2 ml of sodium heparinized blood of the cord also is very good because that helps us to do the karyotyping. If that's not possible, at least the 2 ml EDTA cord blood is very important. 2 centimeter of umbilical cord from the placental end, it's in the normal saline can also be put in. These can be taken from the baby's head most commonly, and then 2 to 3 centimeter, 2 cross 2 cross 2 centimeter of thigh skin sample that has to be taken, put it in the normal saline again. And after taking all these sample, then the fetus can be put in 10% formalin. And as mentioned by Dr. Aditya before, put it in a large enough container so there is no artificial contractions developing due to the confinement of space in this container that we are sending. So EDTA blood, umbilical cord, EDTA blood from the cord and umbilical cord itself and skin sample of the thigh is very important. Now, then it goes through process of storage and allowing to fix. This takes a period of 3 weeks at least to 1 month to allow it to fix. Now, there is a procedure where we actually try and inject formalin into the thorax, abdominal cavity, and the brain. So this helps in better fixation and prevents autolysis. This also is very common to have a lot of autolysis to our samples. So proper storage and proper fixation procedure needs to be followed prior to doing any autopsy procedure. Now, skeletal radiographs generally prefer to take after 10 days of fixing. That's the protocol. Now, AP and a lateral view has to be taken and can focus on any specific part also, like you're looking at mesomelic dysplasias. So you can take a more detailed view of lateral view of the forearm bones and so on. So they can focus on the specific part. But at least a basic AP and a lateral view has to be there. Now, these skeletal radiographs are very important from a geneticist perspective to understand skeletal dysplasia because they generally don't have a lot of examination findings apart from the measurements that can differ. So, having a radiograph really helps us to make a diagnosis in skeletal dysplasia. Now, once you've done all this, getting things ready, you need to have a proper setup, a splash-proof wall. You need to have your instruments ready. If the baby is, to be given back to the patient, you need to have a suture material ready so you can do that. You should have your measuring tape. You should have your weighing scale and scales to measure harder parts also ready. Now, once we've done that, we do the anthropometry and also put in the corresponding centile for each. Now, this is just like we perform head-to-toe examination of a child once the child presents to us in the OPD. Very similarly, we do this, and the same approach is kind of taken for the fetus also. We try to look at a lot of things, including crown rump length, crown heel length, head circumference, abdominal circumference, chest circumference in those respective diameters to make sure that we are checking the right one. And all these have a centile chart. So we have to understand which centile it falls into to give a more better understanding. The second one, and I think this is where the geneticist perspective comes into picture in the most way, so is to do a dysmorphology assessment. Now, dysmorphology assessment in a fetus is very, very difficult because there is so many subtle changes that generally is so evident in postnatal life, but in the fetus, because of maceration, because of even the gestational age at which we're doing these dysmorphologies can vary very significantly. For example, something as simple as Down syndrome, you can see how much there is a variation. You could probably see a low set ears in most of them, mild upslant in many of them, but not all, and also some wide nasal bridge. These can be seen. But things like epicanthic fold, flat mid faces, filtral abnormalities, lips abnormality, these are very difficult and very subtle to pick in the autopsy period. So a trained eye can only pick up these dysmorphology assessments very well. Now, for example, you can see this is in postnatal life. If you look at the child's photo, you'd be very easily able to say this is Seckel syndrome. But in a child, this is a little more difficult. You have to pick the right things. Like you should see the micrognathia, which is there. You should be able to see there's a microcephaly. Also document the microcephaly when it is present. These things play an important role, and the peak, a prominent beak nose, which is generally seen with Seckel syndrome in the postnatal life, it can be seen in prenatal life only with some examination and understanding of it. So that's a very important trick to look through very carefully. And this is again an very easily pickable finding in the postnatal life, like frontal bossing and hypertelorism and Robinow syndrome. But for us in the fetal life, this is much more difficult. Very subtle frontal bossing, hypertelorism though very prominent. And of course, the short limb dwarfism is seen. That's why measuring and putting it in the centiles for each of these places are very important, and taking the x-rays to find the vertebral segmentation defect is very important. Once you have done all this, like Dr. Aditya said, we also look at external examination, look at skin, forehead, eyes, ears, jaws. So making this list of what you need to look at will make sure that you haven't missed anything out. And this I want to point out here is this is how you take the skin sample from the thigh. So you can see how it's taken. Generally, this is the preferred technique to take the or preferred way that we take the thigh samples, skin sample from the thigh. Then we go through internal examination. We always divide it into three parts: the chest, the abdominal cavity, and the intracranial examination. And all the important findings have to be noted down in each of these places. For example, in the thorax, you have to understand whether there's a cardiomegaly or not, whether there's fluid-filled spaces, whether the lungs, pericardial fluid or pleural fluid is present. Then dissect out and open out the heart, and there are specific incisions that we need to make to understand whether there is TOF, there is VSD, and so on. In the last picture, you can see a very clear VSD. So we do the probe test also to understand whether VSD is actually present or not. So these examination, especially for the heart, needs to be very skilled, and only then you can pick up these subtle abnormalities which are either missed on scan or present in scan but not very evident. Then come to abdominal examination. Abdominal examination, we need to understand first whether the situs is maintained, to look at the liver, to look at the intestine, bladder, external genitalia, internal genitalia, make sure that everything is in place. You also need to trace the ureters. You have to look at the kidneys, the shape, structure, whether there is any horseshoe kidney, whether there is joining of kidneys. Also dissect out or make an incision into the kidneys and look for cysts and other forms. So all these are important parts of the autopsy, and each of these steps need to be followed if we need to be thorough in our picking up. Intracranial examination, of course, we do for the surface, we do for the ventricles, we look at cerebellar fossas, we look at corpus callosum, and all of that is taken into account and has to be documented before we move on from the intracranial. Now, once you have done that, all the organs have to be dissected out. They have to be weighed in the weighing scale to understand the centiles, whether they are in the particular gestational age or not. And once you have done all of this, then the organ tissue are all put in formalin in a small box and sent for histopathological examination. Now, once you go to the histopathological examination, you will have to provide what were your gross dissection findings. So in gross dissection finding, if you felt there was focal cortical dysgenesis, the same will be corroborated in histopathology, and based on that, you can make a diagnosis of a Vici syndrome or something else, neuronal migration disorders and so on. Then you have skin and cartilage abnormality because you have abnormal joint positioning, very lax joint. Then that particular part can also be looked up in histopathological examination to make a diagnosis. So understanding the gross findings is very key to understanding what we need to look at and what we need to focus in histopathological examination. Laminar calcification, Gaucher syndrome, cardiomyopathy, and storage disorder. Also, all these things together, all dysmorphology together, then we can form our differential diagnosis at this point of time. So here you can see there was a non-consanguineous couple with joint contractures, edema, micrognathia. On autopsy, we found that, so for X-ray, we found that there was scoliosis and joint placements were completely abnormal. Multiple joint contractures were there, dislocations were there in few of them. And on examination in the autopsy, again, there was micrognathia, very loose skin folds. We did then send for histopathology, thinking it could be a collagenopathy. And then the genetic examination could then be determined because we wanted to do a whole exome sequencing, thinking it's a collagenopathy. And we were able to come to a diagnosis of a blended phenotype of Marfan and Beagle. Similarly, this was a case where you had a significant dysmorphism present, consanguineous couple, recurrence of the similar anomaly. You had very evident hypertelorism, malar and mandibular hypoplasia, retinogranthia, multiple joint contractures. CNS showed a lot of abnormality. We had a diagnosis on looking at the baby and putting all these features together that this could be peroxisomal disorders, and we did find a variant in PEX1 gene. Similarly, this was another case, very rare case where Gaucher presents with a lot of hydrops. Hydrops is quite common, but also you had hepatosplenomegaly, which is again seen with a lot of storage disorder, joint contractures, cerebral atrophy and intracranial calcifications, which rare for Gaucher's was seen actually in this case, and we were able to have our prenatal phenotype that it could be Gaucher's, and we did a genetic testing to confirm the same. So the idea to tell you this is a good history, a radiographic examination, putting your autopsy handles together, and then taking the histopathology confirmation, forming a differential diagnosis is key to determining which genetic test should be followed next, and only then you will be able to get a good results in your genetic testing. So this is some good handles that you can see, polydactyly, what to think of, overlapping fingers, what to think of, arthrogryposis, what are the conditions that are associated with it. I've just tabled this up. This is by a paper by Shagun Madam on this, and it's a wonderful paper. All of us can read through it. So based on this, we have kind of an algorithm. So the algorithm, whenever you have a fetus with abnormality, an ultrasound and a postmortem examination both give significant clues, where ultrasound is good in picking up malformations, soft markers, liker abnormalities, and others. Postmortem examination is better to pick up the dysmorphologies, isolated malformations, growth abnormalities, organomegalies, skeletal dysplasias, which are very subtle because we do an X-ray, postnatal X-ray for all of these cases. So they are also very important. And also, of course, the histopathological confirmation and placental histopathology gives us that additional confidence. And then you do the invasive test in ultrasound or a fetal tissue sampling. I told you how we do those things, and collect the sample for DNA for genetic testing. Then, based on what differential you have, you choose between the tests that you want to do, either a karyotype, microarray, biochemical testing, exome, and so on. And then you have a diagnosis for the fetal syndrome. So going through the stepwise algorithm is very important. So thank you. Thank you for this wonderful opportunity to present. I'll be happy to take any questions if you have in the future.
Thank you, Dr. Priya and Dr. Ranganathan, for such crisp lectures. And I think there are a lot of take-home messages for the audience today. I think history taking, correlating your phenotype goes a long way in determining your genotype. I think that was fantastic. Thank you so much. A lot of questions have been answered in the chat box already.
Thank you, Dr. Priya. I think we can move on to the next session. So now that we have had the two speakers tell us about a pathologist approaches and how a geneticist approaches an autopsy. So what we need to also realize that a teamwork is really important. So we are trying to catch the elephant from different angles, coming from different specialities, but finally we all have to come together to get the complete picture. So the next session would be helping us in doing that, whereby now we are going to involve the different team members, the imaging specialists, the geneticist, the pathologist, and then we are going to see how it kind of leads to a synthesis or the final diagnosis for a pregnancy which has been lost. So, Dr. Aditi, would you like to introduce the next session participants?
Yes, firstly, I'd like to introduce the chairpersons for this session, Dr. Ratnapuri ma'am and Mocha sir. Both of them really truly don't need too many words to introduce them. They're giants in their field. So Ratna ma'am is the professor in genetics and chairperson, Institute of Medical Genetics and Genomics at Sir Gangaram Hospital. She has numerous awards to her name, and we all really, really look up to you, ma'am. And next, of course, is Dr. Mohit Shah, sir. He's our national president of the SFM, and he's also the national president of the Musculoskeletal Ultrasound Society. And thank you so much to both of you for being here today. First speaker for this session is Dr. Sushila ma'am. She is the senior consultant and head of academics of fetal medicine at Fernandez Hospital, and she's in charge of the twins clinic. And I would also like to add that she's an amazing Kuchipudi dancer, and she's given many stage and TV shows to that. Thank you, ma'am, for being here today. And I hand over to you for your talk on imaging and autopsy.
Thank you, Dr. Aditi, for the kind introduction. Thanks very much, Mission Mangal and Dr. Shagun, for giving us this opportunity. By now, we all understand that the autopsy is more than a post-mortem examination as far as the cause of death is concerned. That is, when it comes to the perinatology, the stillbirths. So it has more and more inputs, for example, in the helping in improvising our imaging skills and then quality. We have two enthusiastic team members who are going to help us how we audit our images and see what is the ultrasound correlation with the autopsy in these pregnancies with adverse outcomes. Now, first I asked Dr. Seaton. She's a consultant who is going to help us with one of the first cases, followed by Dr. Ramya for another case from Fernandez Hospital Fetal Medicine Department. Seaton.
Hello, good evening all. I'm Dr. Chitin. Just give me a moment to share my slide, please.
Sure. Yeah, we are able to see your slides.
Good evening all. I am Dr. Chitin. Along with Dr. Ramya, under the guidance of Dr. Susila, we are here to present some interesting cases on imaging and autopsy. So my first case, she is primigravida, 28 years, non-consanguineous couple. She came to us for NT scan at 12 weeks, 4 days, where we can see here that the NT measurement was normal. In the structural survey, we can see here that the four-chamber appeared normal. In the color Doppler, we can see that there is a forward filling in both the ventricles. But in the 3-vessel trachea view, we can see here only a single great dilated vessel is visualized. We also see there was no tricuspid regurgitation and ductus venous waveform was normal. So we re-evaluated the fetus at 16 weeks. Here in the 4-chamber view, we can see there's a slight chamber discrepancy where the right side of the heart is a little dilated than the left side, especially the left right atrium. In the 3-vessel trachea view, we can see only 2 vessels, the smaller one being the superior vena cava and one great dilated vessel. In the left ventricular outflow tract, we can see here there's an interruption, which is a malaligned ventricular septal defect, and an overriding aorta draining from both the ventricles. So this is a short clip demonstrating the same, whatever I have explained before. In the 2D grayscale, we can see here that there is a malaligned VSD and a dilated aorta, which we were thinking to be an aorta, but certainly after certain short course, you can see there are branching arising from the trunk. In the 3-vessel trachea view, again, we can see a high velocity in a single dilated great vessel, and also a small branch arising from it. So we ascertain it to be a common arterial trunk giving two branches, one being the aorta and another one being the pulmonary trunk. In the arch view, we could not demonstrate the ductus arteriosus, but the aortic arch was dilated and the bicaval view appeared normal. So my provisional diagnosis is common arterial trunk. At this point, since the common arterial trunk is associated with microdeletions, so we advise for amniocentesis followed by chromosomal microarray, but the patient wanted to undergo termination followed by autopsy. So coming to our sonopathological correlation, the first image depicts the gross external feature of the baby, which appeared normal. When we open up the thorax, we can see out here the trachea and the 2 lungs on both the sides with the horizontally placed heart. Here, just above the heart, we can see thymus, which appeared normal for the gestation. And the third image depicts the neck vessels. So in the neck vessel, we can see out here that the left internal jugular and the left subclavian joins to form the left brachiocephalic vein, which crosses across the mediastinum. And the other side, this is right internal jugular combining with the right subclavian, forming right brachiocephalic, which drains into the superior vena cava. Superior vena cava out here looks congested and dilated. And these two are the branches from the aortic arch, the right and the left common carotid arteries. So looking at our sonopathological correlation, we can see how a normal 4-chamber should look like. They should be proportionate on both the sides. In our case, there was dilatation on the right side. And when we correlate it with our autopsy finding, we can very well see this is the right atrium which was dilated. When we compare it with the normal image, we can see how nicely the right atrium looks like. And the second picture is the 3-vessel trachea view. This is how a 3-vessel should look like. The small anechoic area is the trachea, where 2 great vessels are onto the left of the trachea. Comparing with my case, we saw only 2 vessels, superior vena cava, and 1 great vessel, which is dilated. So what is this great vessel? We should look into autopsy. Here we found that this great vessel, which was dilated, was nothing but the aorta. We can see and confirm by seeing that it is giving the neck vessels, and just below it we can see that there is a pulmonary artery which is very much atretic. So comparing it with the normal autopsy picture, we should see out here that usually or normally the pulmonary is a little larger than the aorta. So when we see the aortic arch, it was a left aortic arch giving 3 neck vessels, but in our case we also found a 4th neck vessel which is traversing behind the trachea. When we see the posterior end, we can see that there should be no vessel traveling behind the trachea. So this was a case of left aberrant subclavian artery. The third image depicts the main pulmonary artery dividing into the 2 pulmonary branches, the dilated aortic arch you can see, and a small adjoining ductus arteriosus. When we come to the left ventricular outflow tract, in our case, we see malaligned VSD. When we compare it with the normal image, we can see that the left ventricle drains into the aorta, and there is a septo-aortic as well as mitro-aortic continuity, which was lost in our case. And when we compare with our autopsy finding, we can see here that the aortic root is quite dilated and it drains both from the left ventricle and right ventricle. When we compare with the normal finding, normal autopsy picture, we can see that the aortic root is solely being drained out from the left ventricle. Coming to the aortic arch, we should also look at the aortic arch because sometimes it can be associated with the left-sided aortic arch. In our case, it was right aortic arch only, and mainly it was a pulmonary atresia. There can be sometimes collateral between the pulmonary and the descending aorta, which was not seen in this case. In the bicaval view, we can see that superior vena cava and inferior vena cava draining into the dilated right atrium. So my final diagnosis is tetralogy of Phow, pulmonary stenosis with ventricular septal defect and aberrant left subclavian artery after the autopsy. So genetic workup was done and the chromosomal microarray revealed copy number variation in the second chromosome, which was a variant of unknown significance. Karyotype of the couple was also done, which was normal. So our plan for our next pregnancy would be follow up with the scans. So talking a little bit about TOF with pulmonary atresia. Earlier, it was also termed as severe tetralogy of Phow, but now it is only called tetralogy of Phow with pulmonary atresia, where there is an atresia of the pulmonary valve, hypoplasia of the pulmonary tract, membranous and infundibular VSD, and overriding of the aorta, which we saw in our case. In 20%, it comprises of 20% of the TOF cases and represent around 2% of the cyanotic heart disease. It could also be associated with trisomy 21 and 18, microdeletion, Vactal syndrome, GI abnormalities, CNS anomalies, and skeletal syndromes. So this is the differentiating feature between the common arterial trunk and TOF with pulmonary atresia, where aortic root is markedly dilated in both the case. The main differentiating feature would be the second point, but the pulmonary trunk seems to be arising from a common trunk in common arterial trunk, whereas in case of TOF with pulmonary atresia, it will be narrow, so it will be buried beneath the dilated aortic arch, which might not be visible. There can be association of main aortopulmonary collaterals in case of TOF with pulmonary atresia. Ductus arteriosus can be tortuous and retrograde perfusion in TOF, whereas in more than 50% of the cases, it will be absent in case of common arterial trunk. There can be dysplastic valve in common arterial trunk, and the aortic valve will be normal in case of TOF with atresia, and there will be no regurgitation. Chromosomal aberration like 22q microdeletion will be associated in both, and the prognosis is good in case of common arterial trunk, but they have to undergo repeated operations after delivery. In case of TOF with pulmonary atresia, if it is a prenatal detection, like in our case, it was from 16 weeks onwards, depends on how is the growth of the pulmonary artery. Since it was quite atretic in our case, the prognosis was guarded. So this is a very clear distinction between the TOF with pulmonary atresia, where we can see the discrepant size between the two great vessels. This is the atretic pulmonary artery and the dilated aortic arch, whereas in case of common arterial trunk, we can see a huge markedly dilated trunk giving rise to the two great vessels. Also in the third image, this depicts that a trunk giving rise to the neck branches, which is the aortic arch, and also the pulmonary artery is coming from the same trunk. So moving on to the second case, she is 25 years primigravida, non-consanguineous couple. She came to us for NT-scan at 12 weeks, 4 days, where we see the first image showing CRL, but subjectively there was oligohydramnios and less liger. When we measured the NT, it came to be 2.7 millimeter, which turned up to be increased NT more than 95th centile. This is a sagittal section showing the bladder, which was enlarged 1.1 centimeter. So we can call it a megacystis. Also a keyhole kind of appearance was visualized. So there was also a single umbilical artery. Because of the oligohydramnios, there was difficult in scanning and because of the poor acoustic window, but we could somehow visualize the spine, which appeared to be normal for that gestation. This is a short clip showing the lower limb. When we visualize the lower limb, only a single lower limb was visualized with the 3 segment. And to notice here that there was a fusion of the 2 femur. There were 2 femur in the thigh. So moving on to the next clip out here, we can see that there was an anechoic mass just at the lower end of the lumbar region, which could not be well appreciated or differentiated than the bladder. So the provisional diagnosis after a scan was increased NT, megacystic, single umbilical artery, serenomelia, and oligohydramnios. So at this point, chorionic villus sampling was done and chromosomal microarray was sent, which turned out to be normal. But because of the guarded prognosis, they opted for termination of pregnancy and autopsy. So coming to a sonopathological correlation, this is the external examination of the baby where we can see a single lower limb out here. The increased nuchal fold is well appreciated with nuchal edema. And in the third image, we can see dysmorphic faces, broad forehead, depressed nasal bridge, but it could be because of subcutaneous edema as well. Here we can see that there was a single lower limb, fusion of the femur, which is consistent with our scan finding. And there was also talipus with pre-axial polydactyly. First and second digit, there was syndactyly, and the last 3 digits appeared normal. When we see the posterior aspect or the back, at the sacral end, we can see a bony prominence, and just below that, we can also see a skin tag. The anal opening was not there, so it was a case of inperforated anus. Also, it was an ambiguous genitalia. When we dissected the back, we can see out here there is an abrupt ending of the spine and dysplastic iliac wings with a bony prominence. Beyond that, we cannot visualize any sacral vertebrae. Coming to our internal finding, here we can see that this is the stomach continuing as the small intestine and the large intestine. But the large intestine or the large bowel is ending into a dilated pouch-like structure. So there was an anorectal atresia. When we compare this with the normal finding, we see how this large bowel is ending into the anus and rectum. So it was a case of high anorectal malformation. Next image here, we can see that this is not the kidney, but the dilated or enlarged adrenals. Bilateral kidneys were not visualized. The center part is the aorta, which is continuing as the umbilical artery. When we compare it with the normal image, we can see how a kidney should look like, and just above it, you can well appreciate the adrenals as well. We can also see the ureter draining from each side of the kidney, and we can also see the internal gonad, which is the testicle. In our case, it was also a testicle, but the external genitalia was ambiguous. This is an image showing the aorta where it is not bifurcating, nor it is giving any renal arteries. Rather, it is directly continuing as the single umbilical artery. So our final diagnosis is Serenomelia type 5. Also, we can call it as a caudal regression sequence. Since it is sporadic or multifactorial, so our counseling for our next pregnancy would be monitoring by serial scans, as there is a very low recurrence risk. So there are 5 types of Serenomelia classification by Renshaw. Our type was the 5th type, where there's a fusion of the bones in the lower limb. We're talking a little bit about caudal regression sequence or Serenomelia sequence. So this is a condition which occurs as a part of various abnormality of lower limb, bowel, genitourinary tract, and caudal spine. It could be existing, there could be an existing maternal diabetes, where we can see in more than 50% of the cases. If the patient takes any teratogen or vitamin A during the 3rd week of life, which hinders with the notochord formation, there can be this anomaly. Also, there can be some genetic association like HLX-B9 home box gene mutation or deletion in the 6th or the 7th chromosome. We have also seen it to be a part of some syndromes like Bacterial, Currarino syndrome, and it has guarded prognosis. Now I hand over to Dr. Ramya for the further case. To our next case, Mrs. A, 33 years, not a mother, non-consanguineous marriage, RH positive blood group, gravidafor para1 live 1 A2 with a previous history of ectopic, previous term LSCS, previous spontaneous miscarriage at 8 weeks, has booked with us at 90 weeks. Her NT scan and FTS for a first trimester screen were done elsewhere, which were normal. At 19 weeks, the ultrasound findings were there was subcutaneous edema, ascites. The picture was suggestive of non-immune fetal hydrops. The MCA PSV was in the non-anemic zone. Coming to the cardiac findings, we can see that there is gross cardiomegaly and the cardiothoracic ratio was 0.76. There was severe left axis deviation. The right atrium was grossly enlarged. The right atrium and the right ventricle were disproportionately large compared to the left atrium and the left ventricle, and there was severe tricuspid regurgitation.
The provisional diagnosis was given as non-immune fetal hydrops for the probable cardiac cause, but the actual exact cardiac etiology and the nature of the cardiac disease could not be ascertained because of technical challenges of gross cardiomegaly, the fetal position, and polyhydramnios. Coming to the etiology of non-immune fetal hydrops are multiple and varied, and the cardiac causes encompass 17 to 35% of the cases. Tricuspid valve dysplasia and Epstein anomaly fall under the structural defects of cardiac anomalies. Coming to the genetic workup, a detailed genetic counseling was done, guarded prognosis explained, amniocentesis done, and the whole exome sequencing revealed no pathogenic or likely pathogenic variants, and the couple opted for termination of pregnancy. Coming to the autopsy, the findings, there was at the gross examination, we can see that grossly the head-to-toe examination was normal. There was generalized subcutaneous edema, abdominal distension due to ascites with hydropic changes. Coming to the internal examination, once we cut open through the thorax, here we can see this is the anterior view of the thorax. Here we can see that the heart is in the normal specimen. We see that the heart occupies 1/3 of the thoracic cavity and the remaining chest is occupied by the lungs. The apex of the heart is deviated to the left and is formed by the left ventricle. Here we can see that the lungs surround the heart in the posterior and the lateral aspect and almost extend up to the anterior aspect of the heart. In our specimen, we see that the heart here, there is gross cardiomegaly and is occupying more than 1/3 of the thorax. There is severe left axis deviation. The apex is formed by the right ventricle, and we can see that the lungs here are only visible in the posterior aspect, and they're severely hypoplastic, and we cannot see that they're surrounding the lateral aspect and encroaching the anterior aspect. So this is the anterior view of a cut section of the lung and the heart. So comparatively, here we can see, compared to the normal specimen, that there is gross cardiomegaly. So this is the normal specimen of a fetal heart. So this is the right atrium. This is the right ventricle. This is the left atrial appendage. This is the left ventricle. This is the interventricular septum. Here we can see that the pulmonary artery is arising from the right ventricle. There is crossing of the pulmonary artery and the aorta. The aorta is basically identified by the branching vessels. If we compare our specimen, we see that the right atrium is grossly enlarged. The left atrial appendage is enlarged. The right ventricle is enlarged, and we cannot identify the interventricular septum. The apex is formed mainly by the right ventricle, and from the anterior view, the left ventricle could not be identified. So this is the specimen from the posterior aspect of the normal lungs. Here we can see, compared to the normal lungs, the lungs are severely hypoplastic and only occupying the posterior aspect. So this is the normal right atrium and the superior and the inferior vena cava. Here in our specimen, we see that the right atrium is extremely enlarged and the dilated superior vena cava and the inferior vena cava draining into the right atrium. So once we cut through the right atrium, we can see that both the smooth and the trabeculated part are enlarged. There is dilated foramen ovale and the tricuspid valve annulus appears enlarged. When we cut through the right ventricle, we can see that this is the AV ring. The anterior, the posterior, and the septal leaflets of the tricuspid valve are seen to be arising at the normal anatomic location of the AV ring. And we can see that the entire right ventricular cavity is trabeculated, means that there is no atrialization of the right ventricle. And the specimen of the valve has been sent for histopathological examination. In this fetal heart specimen, this is the anterior view. Here we can see that the pulmonary artery is seen to be arising from the right ventricle. There is crossing over and the aorta is identified by the branching vessels. and the caliber of the pulmonary artery is larger than the aorta. In our specimen, we see that the pulmonary artery is arising from the right ventricle. There is crossing over seen, but the pulmonary artery is narrower compared to the aorta. And we also see that the branches of the pulmonary artery are hypoplastic, and this is the ductus. Coming to sonopathological correlation, in ultrasound findings, we saw that the right atrium and the right ventricle were disproportionately enlarged compared to the left atrium and the left ventricle, and this was confirmed in the autopsy findings. There was technical challenge to determine the anatomic location of the tricuspid valve leaflets due to gross cardiomegaly, but the autopsy helped us to identify that the tricuspid, anatomic location of the tricuspid valves, and they were seen to be at the normal anatomic location at the AV ring. Coming to the summary of the autopsy findings, there was gross cardiomegaly, lung hypoplasia. The anterior, posterior, and septal cuffs of the tricuspid valves were seen at the AV ring. The pulmonary trunk arising from the right ventricle was found to be atretic with hypoplastic branches. Coming to the sonopathological correlation, the provisional diagnosis by ultrasound was non-immune fetal hydrops with probable cardiac cause. The exact nature of the cardiac cause has been confirmed as tricuspid valve dysplasia in autopsy. Did sonographic and autopsy findings agree with each other? Yes. And did autopsy add more information in this case? Yes. Coming to the discussion, the differential diagnosis of tricuspid valve are primarily Epstein's anomaly, pulmonary atresia with intact ventricular septum, and premature closure of ductus arteriosus. The anatomic differentiation of tricuspid valve dysplasia and Epstein is that in tricuspid valve dysplasia, the leaflets are thickened with rolled up edges at the normal anatomic location. Whereas in Epstein's, we can see that this apical displacement of the septal leaflet with atrialization of the right ventricle. Coming to the embryological differentiation, tricuspid valve dysplasia, the primary pathology is in the leaflets with normal delamination process. In Epstein's, there is failure of the delamination process, which is pathognomic. Coming to the ultrasonographic features, the three main differentiating features of tricuspid valve dysplasia and Epstein's are: the first one is anatomic location of the leaflets. Here, this is in this we can see that in tricuspid valve dysplasia, the leaflets are seen to be arising in the normal anatomic location. Here we can see that there is the apical insertion of the septal leaflet in Epstein's anomaly. Coming to the second point, size of the right ventricle. In tricuspid valve dysplasia, the size of the right ventricle is normal, whereas due to atrialization of the right ventricle in Epstein's, the size of the true right ventricle is small. Coming to the third point, the origin of tricuspid regurgitation jet. In tricuspid valve dysplasia, we see that the origin of the jet is from the tricuspid valve annulus, whereas in Epstein, we can see that the origin of the TR jet is from the apical insertion of the septal leaflet. So tricuspid valve pathology can be suspected as early as in the first trimester, around 12 weeks. So in this case, we see that there is that the right atrium is enlarged, there is left axis deviation, and there is severe tricuspid regurgitation. In follow-up scan, it was confirmed as Epstein's anomaly. Coming to the associated abnormalities, tricuspid valve and dysplasia and Epstein's are associated with trisomy 18 and 21 respectively, according to the recent studies, and they warrant invasive testings. The associated cardiac defects are: right ventricular outflow tract obstruction is more common in tricuspid valve dysplasia, and the differentiation of pulmonary atresia, functional and anatomic, can be confirmed in autopsy. Coming to the pathophysiology, the detrimental effects on the fetus is primarily because of the pathological sequence of severe tricuspid regurgitation. Whenever there is severe tricuspid regurgitation, the afterload in the right ventricle increase, and there is right ventricular hypertrophy. Right ventricle is extremely enlarged, which causes right ventricular failure. And this causes left ventricular compression, ultimately left ventricular failure, and this causes low combined cardiac output, IUGR, sudden IUD, the neurological sequel occur, and there is raised central venous pressure, which gives rise to hydrops. Gross cardiomegaly will give rise to lung hypoplasia. Because of the severe tricuspid regurgitation, this backward flow into the right atrium, and the right atrium is extremely dilated, and there are pressure effects on the AV node causing arrhythmia, and right to left shunt and with dilated foramen ovale. Because of less pressure in the right ventricle, there is left to right shunt and reversal in the ductus arteriosus, causing a circular shunt, ultimately leading to pulmonary regurgitation, which is a very poor prognostic factor. All the detrimental fetal effects are primarily because of the low cardiac output. Coming to the prognosis, the overall perinatal mortality rate ranges from 17 to 56%, and they have the prognosis depends on the severity of the disease. The poor prognostic factors are early gestational age at diagnosis, large tricuspid valve annulus, pulmonary regurgitation, pericardial effusion. To conclude, the difficulties in differentiating tricuspid valve dysplasia from Epstein's due to inherent limitations in fetal health can be resolved by fetal autopsy. Fetal autopsy is like a quality indicator, and autopsy remains a gold standard even in the era of modern imaging technology.
Thank you very much, Ramya and Seaton. I'm sure people might have enjoyed the correlation and also the importance of pathophysiology, which help us to understand the disease process better. So we already know that perinatal pathology has lots of clinical significance. In our study, what we wanted to show case discussions is that it helps in the audit of our specific conditions, which we pick up on the ultrasound. I'm just taking 2 minutes of your time to take you how the technology has evolved over decades. For the past 2 decades that we have been practicing fetal medicine at Fernandez Hospital, we have this sonopathological correlation in place. You can see decades ago, perhaps, the anencephaly has come out as a surprise. This is not a surprise in 2000, beginning of millennium, where the women informed choice continued her pregnancy and had a neonatal death. But I am sure that all of you are aware that we can pick up anencephaly as early as 11 weeks of pregnancy. This is the encephalocele, which was picked up in the mid-trimester. You can see the sonopathological correlation. Whereas by 11-12 weeks of pregnancy, we can identify this particular encephalocele in the modern era. There is no excuse to miss this. And also, you can identify the sonopathological correlation in the same specimen. The limb body wall complex comes as a shock to the parents, used to come in the mid-trimester, whereas now we do have this limb body wall complex, which is a lethal malformation, again, picked up as early as 11 to 12 weeks of pregnancy. Third trimester cyclops, which is a shocking again experience. You can see the 3D 2000s that we did, and then you can also see the cyclops, which is sonopathological correlation. Whereas now, in that sense, we are fortunate to pick up these abnormality as early as 11 weeks. You can see the 2 eyes and then proboscis, which correlates, well with the cyclops. The cleft lip and palate, again, in the 3rd trimester, and then women will continue, and then because it is a surgically correctable. Whereas in this specimen, we can see the 3D picture, which showed the cleft lip and palate correlated with this specimen. Apart from that, baby also has, polydactyly. Therefore, this has a much severe pathology when compared to isolated cleft lip palate, and therefore the couple opted for interruption of pregnancy. The cardiac specimens are well shown. This is the common arterial trunk, which we dissected in the mid-trimester. You can see single vessel coming from the heart, and then all the great neck vessels, what we call. This is the posterior side, which showed the common arterial trunk with the 3 neck vessels. Also, you can appreciate the both branched pulmonary arteries coming from the same, that is CAT, common arterial trunk, which already our team has shown here, the common arterial trunk from where the pulmonary as well as the aorta, this one with descending thoracic aorta, arch of aorta, descending thoracic aorta with the great neck vessels, which was picked up as early as 11-12 weeks pregnancy. The Serenomelia, which came as a referral for oligohydramnios, we identified at 33 weeks. This particular specimen is around 30-32 weeks pregnancy, which is again a very shocking experience for the women as well as us. And now, thankfully, to the recent technological improvements, you can identify both the upper limbs, whereas single fused lower limb, which constitutes the Serenomelia in this particular case. Megacystis or lower urinary tract obstruction. This is the ocal that we have applied again around 2000, this particular specimen. You can see dysplastic kidneys, the ureters, and a big keyhole bladder, which actually can identify in the megacyst as the first trimester prevalence itself. And then these women opted for continued because she wanted to test whether the kidneys improve. And then she had a termination of pregnancy. You can see again the same megacystis, which is picked up as early as 12 weeks gestation. So, ladies and gentlemen, thanks very much for this, wonderful opportunity for the Fernandez Hospital. Any questions? We are very happy to take. Thank you, Shogun.
Thank you so much. They've been excellent presentations. Hi, Dr. Sushila.
Thank
So
you,
there are
ma'am.
2 questions in the chat box whilst we go to the next session. I think I'll request you to answer the questions there. And now we invite Dr. Shagun Agarwal and Dr. Ashwani Tandon to the next part of this. So Dr. Shagun, we all know, is the additional professor and head of the Department of Genetics at the NIMS. And she's done a lot of work in fetal autopsies and published extensively. And so, Shagun, you'd be starting?
Ma'am, I have a
Yes, ma'am.
small
Please
request.
first, yeah, we'll go on
Yeah,
to the partner
Aditi, take it
videos.
forward. Yeah, take it forward.
Ma'am, there's a
Aditi.
small request. We would request to just take a quick look at the trade partner videos before we start.
Okay, okay.
Thank you.
Thank you.
Right. Thank
Dr.
you so
Aditi,
much.
can you display the Dr. Ashwini Tanda's CV slide?
Yes, ma'am, I'll just do that.
So, as I mentioned at the beginning, like perinatal autopsy is basically teamwork. So, we've just seen the excellent presentation from the Fernandez team where the sonological and the autopsy findings, how beautifully we can see the correlation and the additional findings. So, same way, I mean, once we have done the grossing and we've done the external examination part, then the role of the pathologist. Of course, many of the pathologists themselves are doing the grossing part also, as Dr. Aditya has shown. So, but we really depend on the pathologist for one aspect, and that's the histopathology part, which of course none of us can do, and they are the bosses in that. So, I have had the pleasure of working with Dr. Ashwini Tandon when he was there at NIMS, but unfortunately, it's been NIMS loss and AIIMS Bhopal gain. So, he has decided to join there, and now he is the associate dean there at AIIMS Bhopal, and of course professor in the Department of Pathology and Lab Medicine. So he has numerous awards to his credit, many publications, and we have worked jointly a lot on fetal autopsy. So I'm also very thankful to him for many of the learnings which we have had through our work together. So I welcome you, Dr. Ashwini, to this session.
Thank you, Dr. Shagun, for your kind introduction, and we are really nostalgic because we work together, and the opportunity to grow the area of fetal autopsy pathology services at AIIMS.
Your voice needs to be louder, Dr. Ashwini. I mean,
Okay. Am I audible right now?
it's
Am I
better, but
audible?
if it can be increased, yeah, it's better, but if it can be increased further, it would be good.
Okay. Now it is better. Now it is better.
It is very low, sir.
It's very low.
Not clearly audible.
Okay. Maybe a minute, I will connect by mobile and then I will speak from mobile.
Sure.
Just give me a minute.
I think
Are
you'll
you
have to
using
mute
two
your.
devices by any chance, sir? Are you using two devices side by side?
So while Dr. Rashmi joins with his audio, so I'll just give a premise of what we are trying to do in this session. So in the previous session, like we have seen that there are so many additional findings which are coming up once the fetus is brought up for autopsy, and that is helping in refining the sonological diagnosis, and thereby the subsequent testing and the final diagnosis is established, and accordingly the family is counseled or a genetic test is ordered. So what we are going to see through this session now is that even after doing the autopsy and noting all the important points with respect to the radiographs or the external examination, the dissection, the very important component which still needs to be addressed is the histopathology. So there are many couples, I mean, many families who feel very sensitive about an autopsy, and they're not very keen to go on for autopsy. And there is a whole a new kind of a perspective coming onto a minimally invasive autopsy. But we need to understand that there is something which, doing a complete autopsy along with the histopathology still remains a gold standard, actually. And that's what we are trying to see through this session, that how does it really make a difference despite the fact that we have such advanced imaging available and we have such advanced genetic tests available, where we are doing now whole genome sequencing also. So despite that, still something as basic as doing a histopathology is relevant. So that's what we are going to see. So of course, I mean, this is a slide just to show that a fetus with an anomaly or a fetus which has been unfortunately lost due to an unknown reason is one of the category of patient who is very likely to have a genetic disease. And this is really important to diagnose, because we are able to then only counsel these families, guide them for future conceptions, and provide them accurate recurrence risk, early definitive prenatal diagnosis, or even pre-implantation genetic diagnosis. All this is based on making the diagnosis of this index pregnancy or this index fetus, which has suffered with all these the anomalies or a premature loss. So this I'm not going to elaborate. Of course, we have seen this, that we need to collect so much information before the fetus comes in for autopsy, and we have to do all these individual steps, and we have to collect the samples for the genetic testing. Each of these things are important, and each of them come together to give us the final answer. So again, this has been extensively covered. So just to reiterate that, yes, external examination consisting of dysmorphology, taking photographs, and anthropometry does give us the answers. And Dr. Priya has already showed these fetuses with Down syndrome, all of them looking somewhat similar, somewhat different. But then again, a trained eye is able to pick up some dysmorphology. And then so many other genetic syndromes would be having some specific facial features, which again, somebody who's trained in perinatal pathology or a fetal dysmorphology would often be able to make out. And this really helps us in deciding the next step, which is to which genetic test to do. So again, another fetus with a very classical face. This is a condition called as Robert syndrome, with limb reduction defects, more of the upper limb, and so many other anomalies which could be there. And then, of course, the importance of radiographs, how it helps us in picking up various types of skeletal dysplasia like chondrodysplasia punctata or osteogenesis imperfecta, or this is a very rare type of OI with presence of pterygia, as we can see here. This is Brooks syndrome. And finally, of course, it's important to put all these things together to recognize a pattern so that you have a provisional diagnosis in mind, which helps in guiding the further testing. So like this particular fetus with short bones found to have additional findings like a midline cleft, lobulated tongue, polydactyly, and cerebellar hypoplasia and large echogenic kidney. So we have a working diagnosis by the time we are finished with the gross dissection, and that helps us guide, it helps us inform the pathologist, have a conversation with the pathologist as to what we want them to look, and it helps us in also guiding our genetic test. And this Dr. Priya has already alluded to. So now we'll just go on to some cases where we are going to discuss how the crosstalk with the pathologist becomes extremely important, despite the fact that we have a good dissection, we have noted everything, we have a very good sonogram available with us, and we have all the genetic tests at our fingertips, but still pathology remains extremely important. So first we'll see this case where it's like kind of an equal contribution, we could say, of the dysmorphology part and the histopathology part. So this is a pregnancy conceived of a consanguineous couple at 17-18 weeks. A scan done elsewhere showed an parieto-occipital encephalocele, ventriculomegaly, and a two-vessel cord. So this is a family pedigree. This was their first pregnancy. So this fetus, of course, was terminated, brought in for autopsy. On autopsy, we saw the single umbilical cord and nothing very specific, but just some subtle dysmorphism, slightly muscular appearance of the baby. And this is the defect in the occiput, which can be seen. And when we went on to the brain, there was partial autolysis, but we can see that, yes, there was severe ventriculomegaly, a thinned out cortex, and the corpus callosum was not seen. And also, if we can, somebody can appreciate here, if we look at the margin of this cortex, we can probably see that there is maybe some amount of cobblestone kind of an appearance. So that is what we had at this point of time. There was no recurrence here. So, but because of this appearance of the cortex and the slightly muscular appearance of the fetus, we were thinking that probably could this be some genetic condition. So there was also parental consanguinity. So here we need to remember that unlike other neural tube defects, encephalocele is one kind of NTD, which has a high proportion of genetic etiologies. And these are the two common genetic syndrome, Walker-Warburg syndrome and Meckel-Gruber syndrome. Meckel-Gruber usually will have a polydactyly, but may not always. And it also has enlarged cystic kidneys, which again, this fetus was not having. So we were thinking more of Walker-Warburg syndrome. And then because this condition has certain additional findings, so I spoke to Dr. Rashmi and I requested him, please look for this additional thing. This would really help us in finding out whether this fetus could be having this genetic condition. So then Dr. Rashmi came back with his very detailed histopathological findings. So I would want you to elaborate those, Dr. Rashmi.
Thank you, Dr. Shagun. As pointed out in the earlier slide by you, that there is only the upper area of cortex where the cerebral cortex, both the area toward the sagittal sinus, there is a little appearance of cobblestone, but otherwise it is like a sac or a bag. If you can show the previous picture.
Sir, can you come closer to the
Yeah,
speaker?
I am very close. I am very close, and am I audible right now?
No, sir, you are not very understandable, if I may put it that way. I can hear you, but we don't understand what you're speaking clearly. So,
Okay. So right now what you are able to see is the surface of the brain. Here you can see a bag-like appearance. And if you see toward the sagittal sinus area, here in the top of the surface, the first picture, yeah, here you can see a little attempt of cobblestone formation, which on the cut section, the next picture, here you can't be able to see any corpus callosal area. And again, what Dr. Shagun showed, here there is a little cobblestone. Next slide, please, ma'am. Next slide, please, ma'am. Yeah. So this is the surface of brain cortex. Here, these are the meningothelial blood vessels. So all these blood vessels in the upper two slides are seen congested. And the lower section are from the cerebral cortex. Normally, the cortex is having the all layers. So the layerings will be there. So two layers morphologically on HE we can see, and with much detailed examination we can go to all the 6 layers. But here what we can see, everything is having a mix-up. There is hardly any cortical surfacing. So this is one of the features we can see in the lysencephaly. So this is here in multiple sections in the different part of the cerebral cortex. We are identifying this. Next slide, please. Next slide. Dr. Shagun, next slide. Yeah, this is the area from cerebellum. Here, this is having a normal developmental layering of the cerebellar cortex. Next slide, please. Next one. Yeah, these are the sections from the eye, and here what we can see, the complete lens. Here in the center of the lens you can see some amount of cobulum formation. In the next section you can see the part of cortex and medulla. The part of cortex, there are some attempt of layer formation, 1, 2, 3 layers, you can easily able to identify. But when you are coming in the third picture towards the medulla, there is a cobulum formation, therefore it is having a sort of a cataract. That much only we can see here right now. The next slide, please. This is a skeletal muscle section. Here what we can see, there is a lot of autolysis. So interpretation of the skeletal muscle, the best timing is 6 months after birth. Here we can't give any conclusive remark, but we are just showing what we have seen in the skeletal muscle. It is not contributory or conclusive in this given case. So next slide, please. Next slide. Here.
So I think Dr. Rashmi, in this one, you also reported the retinal detachment here.
Yeah.
In this particular section.
Oh yes, oh yes. This is, but only thing is which we can't be able to substantiate 100%. But yes, on the section, some area it gives us a hint, because the third picture there is a little amount of fluid is seen, though it is not the blood, but there is a little amount of fluid we can be able to identify between the retinal layers. So that's why we indicated that the cataract formation is a confirmatory finding and detachment is suggested. Yeah.
So I think with these findings, when Dr. Rashmi came back with these findings, so now we saw this very unusual, unusual but not unexpected things, because with that encephalocele and that appearance of the brain surface, we were thinking of cobblestone lysencephaly or Walker-Warburg syndrome. And the additional findings, as we all know in this syndrome, are the eye findings in the form of cataract and retinal detachment. And Dr. Rashmi was able to confirm this. So what was looking like an isolated encephalocele on scan, then is suddenly it's like with the autopsy and in addition the histopathology and these very niche findings, what Dr. Ashwini was able to say, we were able to make the diagnosis for this particular fetus. And then we went ahead and did the molecular testing, and we were able to confirm that yes, the fetus was homozygous for this particular variant, and this was the type of this group whole Walker-Warburg syndrome belongs to this dystoglycanopathy group. So we were able to confirm the molecular diagnosis, and then we can see how the recurrence risk now for this family has changed from 5% for an isolated NTD to 25% for this condition, which is an autosomal recessive disorder, enabling counseling, enabling prenatal testing, or even pre-implantation genetic testing. So now I'll quickly go on to the second case. So now here it's like again, so what we saw in the first case was like a crosstalk between us in terms of that both sides we were not sure, but then together the answer came. Here it's like when we were able to kind of recognize certain pattern of findings, and we suggested a particular, again, a diagnosis, and then on the basis of that, we were given very important clues by the histopathology. So this case, Dr. Priya had alluded to her slides. So this was a dichorionic diamniotic twins at 23 weeks gestation. And on scan, both twins were found to have arthrogryposis kind of picture, some cerebral hypoplasia, non-visualization of stomach bubble, and then pregnancy terminated. And the parents also had a similarly affected fetus which had been terminated in the previous pregnancy, and also there was finding of fetal hydrops. So now these two twins were brought for an autopsy. So we can see the hydropic appearance, and we can also see the joint contracture, the clenched fist here, and the talipus deformities in the lower limbs, and some subtle dysmorphic feature. Again, this is the second fetus showing exactly similar findings. So in addition, this fetuses, both of them also had important visceral findings. So both of them had hepatosplenomegaly, and there was also, of course, internal fluid collection. And another interesting thing what we saw is that there was very significant cerebral atrophy in this particular rim and the dilated ventricles also. Both the fetuses had exactly identical findings. So what we had overall was hydrops, hepatosplenomegaly, joint contractures, and also cerebral atrophy. So again, when we put these things together, so that's what as geneticists we do when in clinics also, and of course in case of when we are doing the fetal autopsy and looking from the genetics perspective, that we put together different things and we try to come with a differential diagnosis. So when we put all these together, the first diagnosis which comes is Gaucher disease, the perinatal lethal form of Gaucher disease, because they can these cases can have all these findings. Only a little bit unusual here was the very striking cerebral atrophy. So we had kept the possibility of maybe an additional condition, again a Lisenkeff-Lee kind of a condition here, whereby the CNS finding was giving rise to the arthrogryposis, which could probably be giving rise to the hydrops. So that was what we kept as a second differential, but that doesn't explain the hepatosplenomegaly. So with the first, these differentials, then we again approached Dr. Ashwini and requested him to tell us if there were findings suggestive of Gaucher disease or any other diagnostic entity. So now I'll go on to your findings, Dr. Ashwini.
Thank you, Dr. Shagun. Actually, for the audience, this case is seen and reviewed twice by me. First, blind without having much diagnostic clue, and after having a result, I reviewed the certain organs again. So, what happened in this case, as you have seen, there is a frontal atrophy. The term atrophy, a pathologist is using mainly in the context of dementia in the aged person. But here, if you see the second image of gross, there is a definite less developed frontal cortical area. On the microscopy, if you see the cortex, the top area is having a all meningocortical blood vessels which are congested and red. And subsequent to that, here you are able to see lot of layering, a pale area, then the cells which are seen in the bluish color area, and again a pale area. In this third pale area, you are able to see lamellar, chunky, calcific deposits. And these deposits are somewhat striking. So I jumped and I told Dr. Shagun, look, I am having some very unusual type of a finding. I have not seen yet any cortex with such a type of a lamellar calcification, which I have seen on the von Cosa stain. You can see the down pictures. Here is a darkish greenish black color is seen, and this greenish black color, here what is there is a chunky calcific deposit in the cortex. The similar deposits were seen in the area of cerebellum also. So that is the first finding, and then I gathered the finding from Dr. Shagun. She said, look, it is surprise for you that you are not having a much vacuolated cells, which is supposed to be like the storage cells in the brain. And this is a case of a storage disorder. Then I gave a relook again toward the abdominal visceral organs, and if you have seen those visceral organs, then there is a gross finding where a little splenomegaly and hepatomegaly was there. Here, there is a amount of autolytic changes. So because of that, initially, I can confess here that I missed those Gauchers. And here you can see those compared tissue paper appearance of those cells which are pale pinkish in color. And these are the hemopoietic elements which Dr. Shagun is showing by the arrow. And those two large cells in this picture which are pinkish, yeah, these globules, these are the storage cells. Next slide, please. So the similar findings are seen in, I think, both the fetus, if I am remembering correctly, and those were the storage cells. Next. So, yeah, Dr. Shagun, you can continue.
Yeah. So once Dr. Ashwini confirmed the presence of these storage cells, so then we were again sure that yes, we are dealing with the perinatal lethal Gaucher disease, which is what we had kept as our first differential. Only thing, of course, again, still we were a little concerned about the unusually severe cerebral atrophy and extensive brain calcification. But then when we reviewed literature, so I found there is one publication in which they had three fetuses with Gaucher disease with some amount of brain calcification, but it is not that extensive as our case. So we had still kept a pseudoTORCH syndrome as one of the additional differentials because we know this condition, one of subtypes can have significant calcification also. So then, of course, at that particular point of time, NGS was not that easily available. So we went ahead and we did testing for Gaucher disease by doing the sequencing of the particular gene, that's the GBA gene. And we were able to show that there was a 55 base pair deletion, which was seen in the fetus. And both the fetuses actually were having this. And this actually, in fact, reflects another interesting event, which we call as a gene conversion event due to presence of a pseudogene of the GBA gene. So finally, we were able to confirm that yes, these fetuses were affected with perinatal lethal type of Gaucher disease, supported, of course, by the histopathological findings. So, of course, after this, we can counsel the family and provide them prenatal testing options. So, I think Dr. Ashwini, do you want to say something on these slides?
Yeah, here what we are able to see the top slide I am not able to conclude much, but the second picture, the first one at the top, yes, this one, here you are having a pale pinkish color cells, those are the Gaucher cells and those are the histiocytic in nature. Then the second picture which is in the gray scale is the electron microscopic finding of some storage deposits. The last picture where you are having lot of golden brown color is a immunohistochemistry. Those are the deposit of CD68 positive cells and the cortical plate in the liver. So those are the deposits like that it is. So this is I think our picture in which is little unique in identification. Thank you, Dr. Shagun.
Thank you. So we'll quickly go to the third case then. Here, in fact, the clinical diagnosis or the autopsy did not really give us any answer. And it was the histopathology which made us think that it could be a genetic etiology, and then it helped us in guiding the test also. So this was a pregnancy conceived of non-consanguineous parent at 14 weeks, referred with a positive double marker assay. So at the for given an appointment for amniocentesis at 16 weeks, at that point of time, the ultrasound showed grade 3 echogenic bowel. Because this everybody knows, I will not go on to these details. So amniocentesis was done at this point. Karyotype came out to be normal, and CFTR4 common mutations were also normal. There was no evidence of any torch infection. And then we call this, so at that point we reassured the family. So again, this was like a little older case when array and exomes were not that easily available. So it was not really used in the prenatal setup as such. So then at 24 weeks, when we call the fetus for the family for a follow-up, so then now by this time, the baby had developed multiple prominent gut loops extending right till the pelvis. So we had thought that this could probably be a anal atresia or a lower anorectal abnormality or some other gut malformation. And we'd also kept a differential of possibility of Hirschsprung disease. So after counseling regarding the relatively good outcome for anal atresia with the possibility of Hirschsprung as one of the differential, the family actually decided to terminate this pregnancy. And this was the fetus. We can see the nice anal opening here. So it was nicely pated. Nothing significant as far as dysmorphism. Some gut bowel, the loops did appear to be somewhat dilated, but that's it. There were no other really any findings. And at this point, again, Dr. Ashwini came to our rescue. So by the histopathology of the gut, he was able to say that yes, there is agangliosis in the gut mucosa. I think we don't have photos of this particular case, but these are the other representative pictures from literature. Dr. Ashwini, would you like to say?
So, what happened to me in this given case is when Dr. Shagun said we did the CFTR gene testing and is not giving any meaningful data. Can you have a can you give the histopathology of this case, keeping more interest toward the dilated bowel loop? And her diagnosis was Hirschsprung, and this was the first case I was not aware of when actually those ganglion cells start appearing in the gut. To be very frank, so my challenge starts from that area, and again we are reading because making a confirmatory diagnosis, the pathologists have to do the enzyme histochemistry for acetylcholinesterase, and that is not available. Neither it is available, not we can do in the formalin fixed tissue. So while going through at that given point of a time, we had calcitonin type of a marker, and that marker we did with the control, and across the length of a bowel everywhere it was found absent. So here what you are seeing, all the golden brown color tiny dots, so those can be the Mischner's and Harvard plexus ganglion cells, and those were absent because they are not supposed to be present. The definition of Hirschsprung disease is no ganglion. Once there is a no ganglion, then only we can say that it is a case of Hirschsprung. Now, as I told at that given point of a time, that was the first case and was a challenging case to me also. I requested again Dr. Shagun, can you proceed with the targeted testing for RET mutation? So, and also said that this is a different in comparison to the RET testing for the medullary thyroid carcinoma. So, there we evolved significantly, and then the story is Dr. Shagun's. So, she can continue further. Yeah, here this is a representative where you are not able to see any golden brown color cells deposit in the area of intestinal colonic type of area or toward the wall where Mischner's and Orbit plexuses are there. So nothing. So once that type of a scenario is there, then you have to proceed with, because the main challenge is no fresh tissue available. So that was a period where we have to have a challenge. Yeah, please.
So with these findings from Dr. Ashwini, so now we were again feeling confident that probably this is Hirschsprung disease. So we went ahead and we did an exome sequencing on the stored fetal DNA, and we were able to find a mutation in the red gene, and red gene mutations are known to be associated present with Hirschsprung disease as one of the phenotype. And this variant was actually previously also reported in an individual with Hirschsprung disease. But here, because this is a dominant condition, so we tested the parents also for this particular variant. So actually the mom also was carrying the same variant, so which we saw here by doing a Sanger sequencing. So but she was asymptomatic. So this is something which is known for red mutation. And this is a phenomenon of incomplete penetrance, whereby not everybody with the mutation will develop the disease. So the mom was asymptomatic, but they did have a 50% recurrence risk now in their subsequent pregnancy of the fetus inheriting the mutation. And in fact, this family went ahead and in the second pregnancy, they did a CVS also, and the fetus did have the variant. But again, they went through extensive counseling that there could be incomplete penetrance and let's wait for the scan findings. And they did that and they waited for the scan findings. And fortunately, that fetus, the scan remained normal and that was a girl baby and she remained okay. So again, she also had incomplete penetrance. And in fact, for RET mutation, it's known that the penetrance is more in males. That is, males with the mutation are more likely to manifest. So we don't know. I mean, the exact mechanisms are not really known for these kind of incomplete penetrance. There are various theories about it. So basically here we were kind of, because of the histopathology, we were able to reach a molecular diagnosis. And another important thing is that this RET mutations can also present within cancer syndrome, that is multiple endocrine neoplasia type 2. Sometimes some patients can have both things. So here we were able to advise surveillance to the mom who was carrying the mutation for these particular other cancers which are associated. So now we'll go on to the next case, whereby the histopathology helped as a tool for doing the NGS analysis. So as I mentioned at the beginning of this session that yes, we have now genome-wide test available like microarray, next generation sequencing, and we anticipate that yes, these tests should be able to give us the answer or be able to give us the genetic diagnosis. So why do a histopathology? Why do an autopsy? But as we can see, everything counts, every single point becomes important. So here, this particular family, a consanguineous couple, their previous child had died with developmental delay, and that child had a complete corpus callosum agenesis. And in the next pregnancy, again, the fetus was found to have a corpus callosum agenesis. And this particular pregnancy, because of the prognosis in the first baby, they decided to terminate this fetus. On autopsy, actually, grossly, there was nothing except for the corpus callosum agenesis. No anomaly, no significant dysmorphism also. So again, we were still thinking that, is it like, was it too hasty to terminate this pregnancy? But then again, histopathology told us otherwise. So, Dr. Ashwini?
Yeah. So here we can see some surface area which is having a cortical layering, but if you study in totality, multiple sections, the second section, there is a abrupt cortical layering and some layer are showing duplication on the top of surface. When we move next slide, toward the ventricular surface, lot of congested, dilated vascular spaces are seen. So those are the spaces we can see, and some other area in the brain. Next slide, please. Here, what we are able to see, there are accumulation or aggregates of dysgenetic neurons. So here these are the islands in the higher magnification we can see. Now when this is the morphology, we know that this type of a morphology we can see a patient can throw the scissors. And if we go with the history of a surviving kid, was having the history of seizure disorder. So this morphology of current slide is going hand in hand with the seizure disorder, and then more discussions between me, Dr. Shagun. I think Dr. Ashwin Dalal was also involved in that analysis in initial part, if I am remembering correctly. And then
Yes.
Dr. Shagun proceeded with the whole exome sequence. Yeah, please continue, ma'am.
So actually, this was the first fetal exome which we had done. And this particular case, we were able to find a mutation in this very rare condition, which is called as Vicky syndrome. And whereby there are so many other findings also which are there, which of course we can make out in the fetus. But when we review the records of the previous child, we find that that child did have these additional findings which had been missed previously. So again, combining everything and especially the clue given from histopathology, it kind of helped us in guiding the testing, interpreting the test reports, also correlating all the findings together. So I think this would probably be our last case, whereby despite doing an NGS, despite getting some variant, we still were not sure, and it's the histopathology which gave us the answer. So Dr. Priya alluded to this case in her slides. So this was a 29 weeks fetus terminated because ended up with a preterm delivery, a stillbirth, and had joint contractures on scan. And this is the fetus. So we can see the multiple joint contractures which are there. But in addition, we also see some other findings. We see these loose skin folds everywhere, and we are also seeing some micrognathia, some dysplastic ears, these very long fingers, the wrinkling of the skin. So with all these findings, actually, we were able to suspect that maybe the fetus has some kind of a connective tissue problem. So these were the differentials which we had kept on the basis of the autopsy. So, but still we were not really sure. And here we, by the time the histopathology ran in parallel, we also did an exome. And in the exome, actually the fetus had two variants. And both of these mutations are actually causative of a connective tissue disorder. So FBN1 gene causes Marfan syndrome, FBN2 gene causes Beal syndrome. Both of them are connective tissue disorder. They can present similarly. So again, we went back and then we asked Dr. Ashwini to look at the slides and to see whether there are any features suggestive of connective tissue involvement.
Okay, so here what we did, we took the multiple samples in the different part of body. As far as the skin is concerned, we have seen the palmar, plantar aspect, front, back, neck. Multiple area we have taken the samples, and the morphology is almost one and same, which usually don't occur. If we see the palm and if we see the sole, the thickness of different part of the skin and other things are different in the adult. And here in the first picture, what we are able to see, very, very loose connective tissue in the superficial as well as deep dermal tissue. The dermal appendages are not able to identify. The congested vessels are seen. The collagen tissue is very haphazardly and loosely arranged in the area. So that is a morphological finding in this given case at multiple places. So the next slide, please. Here is a representative of abnormal elastic fiber where the fibrillin 1 gene mutation is there. Here also you can see little loose fiber seen in the area, but this is, sort of an adult and the different area of the skin. Here you can see the epidermal area is having a thickness, but if you see the third picture where the pointer is right now, here you can have a lot of loose tissue similar to the R case. Next slide, please. This is the area of aorta. We rebuild the picture, which is in two of the slides, and we can see here the cell in the light microscopy HND stain is looking unremarkable large blood vessel of aorta. The next slide, please. Special stain, which is not done in this case, but if you see the fibrillin are abnormally deposited in E and F section, which is golden brown. It is having a sort of a lamellar arrangement, which is having a disruption. So that type of deposits are seen in the case of Marfan syndrome. And of course, there are a lot of myxoid change. In our case, there is an area of myxoid type of appearance, but it is not such a pale blue to frankly identify on the light microscopy of HND. We have to do multiple other stains, and it was giving only the hint, but not as myxoid as it is supposedly seen in the other cases. So picture is suggestive, but it is not going toward pakka making a morphological diagnosis type of a thing on the skin. Next slide, please. Yeah, here what we are able to see the cartilaginous tissue. So as earlier slide by our pathologist Dr. Aditya have shown when the normal cartilage development is there and when there is an abnormal. So the first and second section are clearly giving us the hint that is an abnormal developmental cartilaginous tissue is seen and having a lot of myxoid change Areas of sort of an island of myxoid deposits are also seen, which is characteristically not normal for the given patient. So these are the morphological findings we are having in this given case. Up to that only we are able to tell on the histopathology, not a conclusive part, only the observations.
So, with the finding of the gross findings, the histopathology, the evidence which was there, and the two variants which we found, then we tried to again see which condition the fetus actually fits in. So, we tried to list the features of Marfan syndrome, Beal syndrome. So, what we eventually concluded that actually this fetus had both the disorders, because a single disease cannot explain the severity of the phenotype. So again here, despite finding the variants at that point of time, we needed that histopathological evidence to kind of make the conclusive diagnosis in this case. So these are just some series of cases. Of course, there is a larger series which we have published, whereby we are showing that yes, a very significant proportion of these fetuses which are having morphological abnormalities or are prematurely lost, around 44% in our series at least, we found that they were all having these different kinds of single gene disorders once we have ruled out these chromosomal abnormalities. And in fact, in one of this a smaller cohort, what we did that we tried to see that is autopsy making any difference to our genetic diagnostic yield. So here we found that yes, in around 60% cases, the ultrasound is not enough to give you the answer, even if you do an exome. So you need those additional autopsy findings, those histopathology, to finally combine all the features, and then only you are able to find the mutation in your NGS data. So it's extremely important to do this deep phenotyping, whereby autopsy should be an important component, and histopathology, of course, should be an important part of it. So I would just like to conclude through these cases that both of these, the pathology part, the genetic testing, all this complement each other. So in fact, the previous session we saw how imaging becomes important. Some kind of, as Dr. Ashwini had mentioned, some cardiac defects are better seen in imaging. In fact, some posterior fossa findings also are better seen in imaging. So each of the clue matters, and then we are yes seeing that there is a very significant contribution of genetic conditions, single gene disorders to all these abnormal fetus phenotypes. And by doing this kind of a detailed workup only, we are able to kind of get an answers for many of these families and help them. So I think with so we come to the end of Dr. Ashwini. Do you want to give any your comment?
I am really thankful to the complete society, especially Dr. Shagun. I worked in a very close proximity and remembering those days where we worked. And with the help of Dr. Shagun, International Academy of Pathology Media teaching program on fetal autopsy and perinatal autopsy we conducted, where 6 country participants were there who learned a lot and developed how to approach towards the fetal pathology. I think Dr. Ratna ma'am was also there in one of the sessions. So we are thankful, madam, and nice to see you again. It is giving us a very sweet memory. ICMR is trying to formulate some sort of a consortia or some type of a thing. But for last 2 years, which is shortlisted our proposal, the histopathologists are very few in the country who want to give a little dedicated time in this area. Many pathologists are doing ped pathology, but perinatal pathology, handful people are there in our country, and we do want kind support from the group of fetal experts in the country and medical geneticists in the country who have a very passionate way and approach toward this thing. And really thankful to the complete society and Dr. Shagun ma'am, Dr. Ratna ma'am. Thanks a lot. Thanks a lot. And because of you, in AIMS Bhopal also, I developed little courage to start similar services after having a 300 fetal autopsy experience at NIMS. So here now we are developing around 20-25 fetuses in the first 6 months of a year. Some are abnormal, and I do consult Dr. Shagun a lot. I can say I consult Dr. Shagun. Thanks a lot.
Thank you so much. They were excellent presentations and a lot of learning. And I mean, I really think that we keep learning despite how many ever years we've been doing all this work, but every case is a new learning. So it's very, very nice. Dr. Mohit, you'd like to close the session?
Yes, I was amazed by what people are doing, and we still don't know. And we still don't know. Dr. Ashwini, you've doing marvelous work. I love the presentations of Dr. Ramya, Dr. Bhutia. You know, I love the expert comments by Dr. Sushila. And you know, Dr. Ashwini, when you said, can we use ultrasound in postmortem? We unfortunately cannot because of the maceration that happens in the subcutaneous tissues. So when you look at a postmortem baby, you're looking at the external surface. Well, you can derive what you have seen on ultrasound. And X-ray provides an in-depth analysis of the bones. But where it's a clinching thing that you've rightly shown is an autopsy. And you've shown it in multiple of your cases that how autopsy makes you stand corrected vis-a-vis your ultrasound diagnosis. Well, the challenges remain for autopsy: availability, expertise, social acceptance. But I believe you've rightly shown that if you want to conclude and take it to the right conclusion, autopsy is a must. Wonderful sessions. Hats off to all of you. And we still don't know how much people are doing all over in the country, and we're really proud of it. Keep up the good work.
Thank you, sir. Thank you, ma'am. Thank you, Dr. Shagun.
Thank you, Mohit sir. So I think we are already running very late.
Yeah.
Ratna ma'am, any other comments, ma'am? Otherwise, shall we conclude?
Conclude.
So I would just like to give the formal vote of thanks to the MC of today's session, Dr. Aditi, to chairpersons of the first session, Dr. Rima, Dr. Kamlakar sir, chairpersons of the second session, Dr. Ratna, Dr. Mohit sir. Thank you all of you for joining, for all your expert comments, all your encouragement. Thank you for the speakers of the first session, Dr. Priya, Dr. Aditya, for your wonderful presentation and showing us the approaches and how the approaches actually converge together to make it a complete picture for the baby. And thanks to Dr. Sushila and the whole Fernandez team for their wonderful presentations and those beautiful ultrasound and autopsy correlation images. And of course, thank you, Dr. Ashwini, for joining us today, for all your wonderful images and the work.
Shagun, well conducted.
Thank you, Mohit sir.
Technology keeps coining new terms. Ultrasound pathological correlation, neurosonoembryology. Wonderful, but well conducted. Thank you.
Thank
To
you.
Telangana chapter once again. Thank you.
Thank
Well
you.
done.
Good night.
Good night, everyone.